All right, great. So it is 12 o'clock on the dot on this lovely February day. It's hard to believe that it is already February. And we wanted to thank everyone here for joining us. We're talking about bringing the focus to complex care, and we're going to be highlighting one of our best practices today. As you heard, we'll be recording the session, so just go ahead and click OK if you're all right with that. And these slides in the presentation will be posted up on our website for anyone that missed in about a week or so after the events. We'd love to hear who is on the chat today, so please chat in what organization you're with, where you're located, what state, and what your role is within your organization. My name is Stephanie Baker. I'm with Health Centric Advisors, part of the iPro QIN-QIO. I represent our New England states. And joining me today in monitoring chat, we have Kelly Arthur and Angela Diggs. They're with Clarence, and they are within the states of Maryland, Delaware, and DC. So thanks for monitoring chat for us. We do want to make sure we keep chat nice and active, so feel free if you think of any questions at any time to chat it in. And at the end of the presentation, we'll have some time to answer those questions. So with that, we're just going to introduce our speaker. So I want to give her as much time as possible to present on the amazing work that they're doing. So today we have Lee Hunter joining us. She is the manager of integrated care management at Frederick Health, which is located in Frederick, Maryland. She has over 22 years of experience in medical social work and care management within the skilled nursing facilities, hospice, acute and ambulatory care settings, as well as experience with value-based care. So like I said, we'll go through the presentation and have some time for questions at the end of the show. So with that, Lee, I'll turn it over to you.
Thank you so much, Stephanie, and welcome everyone. I'm excited to share with you today a little bit about our integrated care management program here at Frederick Health. I wanted to start off by kind of going over the demographics of where we're located in Maryland. We are, as you can see on the map, we're kind of in the middle of Maryland, about an hour west of both Baltimore and DC. We are the sole independent health system in our county, and our health system includes the hospital, Employer Health Solutions, Frederick Health Medical Group, which is both primary and specialty care practice sites. We also have home care and hospice agencies. And fun fact about Frederick County, we're one of the fastest, or we are the fastest growing county in Maryland. So a lot of patients that our team works with now and look forward to working with in the future. Integrated care management is the care management program that supports both our Frederick Health Medical Group and our clinically integrated network here at Frederick Health. Just a little historical information about our clinically integrated network. We are Frederick Integrated Healthcare Network, which we call FIHN. So you'll hear me reference that throughout the presentation. And the network started in 2014 as an accountable care organization for the Medicare Shared Savings Program. In 2019, we transitioned from the ACO model to a CTO for the Maryland Primary Care Program. And our network provides both administrative, IT, and care management support to the practices that participate with the network. Our largest contract for value-based care is the Maryland Primary Care Program, and we also have additional payer arrangements. Some include care management services and some do not. Again, our CTO for the Maryland Primary Care Program was established in 2019. For those that may not be familiar with that program, because Maryland is such a unique state, the beneficiaries that are aligned to the program are fee-for-service, so traditional, not your Medicare Advantage patients. In 2019, we started with 5 practices, and we currently have 15 primary care practices. that utilize our CTO, and we have about 9,500 beneficiaries. In Frederick Health Medical Group, which is also part of the Integrated Care Management Program, we have 9 primary care practices and approximately 40,000 patients across those sites, which include some of those Medicare fee-for-service beneficiaries, as well as commercial, Medicaid, and self-pay, as well as the health system's financial assistance. So who are we? We are a multidisciplinary care management team that supports primary care. We support our FIHN practices, both employed by the health system and within the community. And we actually just recently added 1 care manager to our team to support one of our specialty practices, endocrinology, because we identified a great need for care management support in that practice. So our team, as I said, is multidisciplinary, always keeping the patient and the family at the center. It includes the primary care provider, our care managers, our nurses or social workers. We have care management assistants, clinical pharmacists, pharmacy tech, behavioral health specialists, and community health workers. So next I'm going to go through kind of the key pieces of each of those roles. So as I mentioned, our care managers are nurses or social workers, and they're assigned to primary care practices. And we really find that that's been a best practice to engage the practice, build relationships, and engage with patients long-term. They are either embedded in the practices or in a hybrid situation where they may be on site at an office building, but go into the practices as needed to meet with providers and patients. And they're really tasked with managing those rising and high-risk beneficiaries. We have risk stratification tools available to us through Maryland's HIE, which is CRISP. And a lot of our engagement starts off during those transitions of care. So patients coming out of the emergency department, inpatient hospitalizations, observations, and skilled nursing facilities. And that team has a lot of flexibility in how they can work with patients. Majority of the work is telephonic, but they can also do home visits and meet patients in the community. So they have a lot of autonomy to go where the patient needs them to be. Our care management assistants on our teams are either medical assistants or CNAs by background. They do a great job in the outreach to patients after a discharge, in addition to the care managers. They assess for understanding of discharge instructions, try to identify any barriers that patients may have in understanding discharge instructions, filling medications. They can schedule discharge follow-up appointments with patients while they're on the phone with them, and also help with transportation as well. So all of that can be taken care of in that one phone call after discharge, which we all know is a really critical time to engage with our patients. We're very fortunate to have 2 clinical pharmacists on our team that can provide comprehensive medication management to our beneficiaries. They also engage with patients during those transitions of care, which is, really important time to look over the medications, any changes, assess for education needs. We find a lot of medication discrepancies, especially when patients are transitioning out of a SNF to home and may have had medication changes that they don't fully understand. They assess for barriers that affect medication adherence, really applying that clinical pharmacist lens to the patient's medical history, current care, and can intervene, and work alongside the care management team to optimize the patient's outcomes. One of the unique things that this team really helps with, and the pharmacists are key, is during Medicare Part D open enrollment, they work with a tremendous amount of patients to help walk them through that process, look at their current drug coverage, their options for the following year, and really understand their coverage, because we all know what plan somebody's on, one year may not be the best plan for them the following year. we actually had a presentation earlier today for outcomes of their work, and there's one patient that they were able to save $24,000 on a year by helping them change over to a more appropriate Medicare Part D plan. So the work that's done there is very significant for both the patient clinically and, from a total cost of care perspective. And then we have a pharmacy technician that is also a key member of our team. She proactively assists with identifying high-risk patients for our pharmacists, especially those that are coming out of the hospital on drugs from, the Beers list. She can help identify an accurate medication history. Medication affordability is a big one, help connect patients to patient assistance programs, work with local pharmacies to set up home delivery if transportation is a barrier, connecting to community resources. Our pharmacy tech is really well experienced and has even helped patients get hearing aids. So there's, a lot kind of outside of the pharmacy tech role that she can work alongside the care team with helping our patients. We are fortunate to also have integrated behavioral health specialists on our team that are clinical social workers and an LCPC that can provide that psychotherapy to our patients needing mental health care. They're connected to our primary care offices, not in the same physical location, but it's really easy to get our patients connected with this team. So there's, no gap in receiving mental health treatment, and they can get that started as soon as possible. A big focus of our program is the Medicare population, and we all know that there's a lot of patients, older adults that have transportation barriers or just can no longer drive. So one of the great aspects to this, in addition to the other care management team, is that the behavioral health specialist can actually go into the homes and meet with patients as well. And they typically start with a goal for it to be short term, and they'll help transition off to a longer term option if that's needed, help connect patients to psychiatry for medication management. So a lot of interventions there. And our community health workers, we're very fortunate in Frederick to have such a great community health worker team. They really work side by side with the care managers and really understand the community that we're in. They link patients to resources, help them set goals. They go to where the patients are. If somebody needs to go to Department of Social Services, they can meet them there and, help them with the paperwork. So we really appreciate all the time that they spend working with patients, because we know that applications and waiting on phones and long hold times, it's really time consuming. So the community health workers are really great at engaging our patients. So that is the highlights of what our team does. And I just wanted to now talk about when we get involved with patients. Mostly during transitions of care. Like I had mentioned previously, patients coming out of the hospital. We also get referrals directly from the providers that are part of our network and different members of our care team. We have risk stratification tools available to us through CRISP reporting services, and since we've been serving the community for some time, our community partners are aware of our programs as well, and will reach out on mutual patients to collaborate. Some of the interventions our team provides is transportation assistance, information referral to community resources. We can help with advanced care planning, such as completing living wills. We get a lot of referrals from primary care physicians on patients that need long-term care planning, and their caregivers need support. So helping drive those conversations to come up with a long-term plan, whether it's, connecting them to resources for in-home care, adult daycare, assisted living, nursing home, just kind of assessing where they're at and providing that information and helping navigate through those resources. We obviously want our patients to be active in managing their own health, specifically chronic conditions. So we can connect them to different self-management programs that are available in our health system and our community. We can help them with goal setting. Our entire team has been trained on motivational interviewing, which has been a great tool to offer to them. And then we have refreshers for that, since it's a skill that does require some practice. And as I mentioned before, we are not just telephonic, we can go to the homes. That's really a great opportunity to get an insight into, problems that patients may be having that they may not be willing to disclose in the provider office. They may not be comfortable doing that there. We can, help them with appointment scheduling. One of the new tools that we rolled out this year was assessing for those social determinants of health. We built a screening tool for that. And I had previously mentioned about long-term care planning. And then we also provide that comprehensive medication management and behavioral health support. Our community partners are different agencies in Frederick County, such as the Department of Aging, Department of Social Services. We've formed partnerships with several private duty companies, home health care agencies. Frederick Health has other ambulatory care management programs. So if a patient is connected to one of those programs and then in turn gets connected to one of our network primary care providers, there's a handoff process from that care manager to ours, so that care management can continue. We work closely with food banks, Meals on Wheels, different transportation services offered through the county and privately, and facilities, pharmacies, and then chronic disease classes. One of the collaborations that I wanted to mention was that with our facilities, specifically our skilled nursing facilities. We know that a transition from SNF to home is a critical time to make sure that, everything is tied up nice and neat in a bow as much as possible. Medications are, that's an ideal time for medication issues to come up. So we do communicate with our SNFs. We use CRISP to tell us, if patients are discharging out of a SNF. We have notifications through that system that we can, have timely follow-up. So we really want to engage the SNF in what we know and also be a part of that discharge plan, especially for our high-risk patients. Clinical pharmacist is a really important role here. And then we can also help make sure that patient gets back into the primary care office, help facilitate discharge instructions, getting back to primary care. And then we can also help refer into the SNFs too for our patients that need long-term care. So there's a lot of collaboration there. I had mentioned earlier about the Maryland Primary Care Program. That particular program has a variety of metrics associated with it, but the care management specific measurements are related to engagement and discharge follow-up. The program says that 5% of beneficiaries should be engaged with care management, and we historically far exceed that 5%. And as of our last reporting period, we're at 20.6% engagement with those 9,500 beneficiaries. So those key touch points, such as the transitions of care, the referrals from providers and other agencies in the community, are key to that engagement. And, we've found the longer that we've been in practices that, patients will talk, families will talk, and, it's not uncommon for somebody to walk into the front desk and say, I heard you have a social worker here, I need some help. So word really gets around, and it's nice to be able to just intervene kind of on the spot when something comes up. When it comes to the discharge follow-up interactions, the program has a requirement that a patient receives follow-up in 2 business days of an inpatient discharge, which includes SNF, and 7 days after an ED visit. And our discharge rates are really wonderful, and we've made a lot of progress over the past few years to where we are at 98% discharge follow-up rates in 2022, and the program minimum is 50%. We have worked really hard to optimize our internal reports and systems to capture the patients that need the follow-up, whether it's through our own internal reporting or through CRISP. So the team has done a phenomenal job at really making sure that they identify and then outreach to those patients during those transitions of care. This next slide is a screenshot of a document that we can provide to patients and our practices to use as a resource tool to help patients choose the right level of care. There's a focus on readmissions everywhere, and this is just a really nice kind of stoplight tool to give patients some key points about when's the best time to go to primary care, when could they consider urgent care, and then emergency department. So this is a good tool to have available for patients. As I start to wrap up, I wanted to share a story about a patient that the care management team worked with starting back in 2019. He was actually referred to our care management team from one of our other ambulatory care management programs, and he established care in one of our network primary care programs or practices. He engaged with the entire team, our care manager, our pharmacist, our pharmacy tech, CCMPs, that other ambulatory care management program I had mentioned. And we were really involved with him for a long time. We educated him on when to go to the ED versus when to call his primary care doctor. The pharmacist was a key member of the team in helping him really learn how to manage his diabetes, helped him with lowering prescription drug costs. Even were able to help him find financial assistance so he could get new eyeglasses and hearing aids at no cost. And they were able to remove a lot of expired prescriptions from his home. So as you can see, his annual medical costs when we first got involved were about $46,000 a year. There's a slight uptick in that, probably because we got him going back to see the doctors and following through with the care that he needed. And then you can see how drastically his annual medical costs dropped after being engaged with the team for that time period. And from the clinical perspective, his A1C when we got involved was 12.5, and 2 years later had dropped to 6.9 with, you know, the interventions from the various members of the team. So I think this story is a great example of how that interdisciplinary approach to chronic disease can really help not only drive costs down, but also improve clinical outcomes.
Wow. Thank you
Okay.
so much, Lee.
Thank you.
That was great. Such an amazing program that you have there at Frederick Health. And like you said, it really speaks to, it takes a team of individuals to help care for your patients. And I think it's really telling, you know, the work that you've done. And it's impressive how you have, you know, the farm tech and so involved in the team, as well as behavioral health specialists and community health workers. And I think there's a few questions. So I'm going to turn it over to Kelly to see if there's any questions in chat. I'm going to stop the share too, so anyone can feel free to show yourselves and ask questions.
Show yourself. Hey, yes, one of the follow-up questions. How did the 98% follow-up with your discharged patients in 2022 affect your readmissions rate? That's always what we want to know.
Yeah, that's a great question. And again, for those not familiar with the Maryland Primary Care Program, there's different metrics associated with it. Obviously, more than just the care management, there's utilization measures as well that are monitored. So I would say that probably finishing out the year, we are performing close to the 90th percentile as far as our utilization goes. I don't know the exact rate off the top of my head, but we traditionally do really well with that with the team and the practices that we work with. And I think that the time frame in which we intervene after a transition of care, as I had mentioned, is really critical because, you know, patients are at the biggest risk of returning, you know, just days after a discharge. So just to have somebody call them other than, you know, we're doing more than just scheduling a discharge follow-up appointment. We, you know, have standardized templates that we use across our programs to really assess for a variety of things during that transition of care. And if, you know, the care manager or care management assistant making that call feels like, you know, I got to call this patient back tomorrow, or I need to go to the house, they have the ability to do that, you know, do whatever's needed for the patient. And they have relationships with the providers. So if they're in the office and, you know, something tells them, you know, this patient might go back to the hospital unless we can get them in today, you know, they can just walk up to the provider and try to intervene, you know, get them a telehealth visit or something quickly where, you know, maybe going through a front desk, you know, you wouldn't have that clinical like assessment piece to it.
Another question is, social determinants of health. Do you have any of those ICD-10 codes embedded in your EMR? How are you tracking them? And then can you give any idea of what your top maybe 3 are? We've got just a few minutes to answer.
Sure. So our screening workflow, if we identify a Z code on a patient, then the care management team is actually adding it onto the problem list of the patient. And then that problem list translates into a dashboard that we can look for trends. Now, we don't bill for our interventions, so although they become part of the medical record, they're not necessarily being billed out for our encounters. I would say our biggest barrier in the community is transportation.
Okay. We do have someone who wants to know where you're located, who's in Baltimore City and wants to connect with you. So I don't know if you have a second, you want to type your email in chat quickly so they can have
Sure.
access to you.
Yep, we're located in Frederick, Maryland, so we're probably about 50 minutes west of you.
And then I had a question about your open appointments. I know that you guys keep open appointments on the calendar
For our outreach.
for your for the physician practices. Do you guys do that? Is that you have slots that are open for like walk-ins or for
most of our practices have an expanded access, whether it's hours later in the evening, but all the practices are really well versed on the program, and you know, they do what they can to get patients in.
Okay.
And care management can help definitely facilitate some of that.
Did
We're really fortunate with the primary care providers that we work with, is that they get it, they value care management, and you know, they think out of the box too when it comes to trying to help a patient.
Angela, did you see anything else in chat? I was not paying
Yes,
attention.
I was just about to say we have one more question, and I know we're getting down to the wire. So we have a question. Can you speak to how you refer to the skilled nursing environment? Is there a person choice component, or does an active participation criteria to support your program need to be in place with the facility?
It's patient choice. If we go out to a patient's home and speak to them or family, and they want to proceed with, you know, whether it's long-term nursing home placement or they're in that 30-day, you know, window after a hospital visit, and you know, we have the 3-day waiver right now. You know, we can provide them a list of facilities in our area, and then we can kind of have them look over it and do their research, and they really drive where we refer to.
Thank you.
Mm-hmm.
Thank you so much. And if anyone has any other questions, you know, feel free to email us and we can get them over to Lee. I know this was a quick snippet. So we wanted to thank everyone for joining us and thank Lee for such an amazing presentation on your program. I definitely took a lot of takeaways from that and probably have some follow-up questions for you as well.
Okay.
So we'll be doing these sessions every Thursday at noon for the rest of the month. So join us next week to hear from South County Health, which is based in Rhode Island. And then the following week, we'll have New York Health and Hospital and Queens Hospital presenting. And then to wrap it up, we'll hear about some mobile integrated healthcare here in Massachusetts. So with that, I know we're at the 12:30 mark. I will let everyone go, and we look forward to hearing from you and seeing you next Thursday. Thank you again so much, Lee, and thank you, Kelly.
Thank you.
Thank you, Lee. It was fantastic. Thank you.
Thanks. Have a good day.
Thank
Happy
you.
Groundhog's Day.
6 more weeks.
Bye.
Bye.